Welcome to ScrubNotes, What to Say in Clinical Encounters. Whether you're heading into an OSCE, starting rotations, or just trying to feel less awkward talking to patients, this podcast is here to help you sound more organized, more confident, and more natural with patients without memorizing long scripts. I'm Kate, a medical student, and I break down simple, repeatable frameworks so you know exactly what to say in real clinical situations. Each episode is short, practical, and focused on one specific skill, with examples of what to actually say in real encounters so you can use it right away. All right, let's get into today's skill. There's a moment in many patient encounters where things start to feel a little awkward. You ask an open-ended question, and the patient gives you their story. And then you think, okay, now how do I actually take control of this? It's that exact moment where a lot of students either interrupt too early, jump into rapid-fire questions, or hesitate and lose momentum. And the tricky part is, this isn't about your knowledge, it's about how you sound in the moment. So today, we're going to work on fixing that transition. Most students understand that you want to start open-ended and then get more specific, but no one really teaches how to move between those two smoothly. And that's where things start to break down. So what's happening? Well, the shift feels abrupt, the patient gets cut off, or the encounter starts to feel disorganized. Sometimes it even feels like you're switching from conversation mode to interrogation mode, and the patients feel that shift. What we want to do instead is have a transition that feels natural, keeps the patient feeling heard, and lets you take clinical control. Because the goal isn't just about information, it's about guiding the encounter without breaking rapport. This is where the next part of the CONNECT framework comes in. In the last episode, we focused on context, open, and narrow. Those steps help you start the encounter strong. Now we're adding N for navigate. This is the bridge, the step that helps you move from listening broadly to guiding clinically. And if open is where the patient leads, navigate is where you gently take the lead back. So step 1 is let the patient finish. Before you transition, you need to create space. Even a 1 to 2 second pause signals that you're listening, you're not rushing, and this is where a lot of students get uncomfortable because silence feels awkward. But in clinical communication, a short pause actually feels respectful, not awkward. So count 1 Mississippi, 2 Mississippi in your head before speaking. This is subtle but powerful. Step 2 is to reflect or anchor on what the patient said. So this is your bridge. Instead of jumping straight into questions, you briefly reflect something they told you. For example, got it. Okay, that's helpful. I hear that has started a few days ago. Notice this doesn't need to be a full summary, just a quick anchor. So why does this work? Well, it validates the patient, it buys you time to think, and it makes the transition feel intentional. And importantly, it shows the patient, I'm not just hearing you, I'm also processing what you said. And step 3 is N for navigate. We want to signal the shift. So this is the missing piece for many people. You explicitly tell the patient you're about to ask more questions. So you could have a soundbite like, I'm going to ask you a few more specific questions to better understand this. I'd like to go through a few details more about your symptoms if that's okay. This is the moment where you take control, but in a way that still feels collaborative. This does 2 things. It removes awkwardness, and it gives you permission to lead. Without this step, the transition feels abrupt. With it, the shift feels planned and professional. So now we're on step 4, where we want to move into focused questions. Now you can cleanly shift into your HPI structure. So some sound bites you could use would be, when did this first start? Where exactly are you feeling it? How would you describe the pain? Now your questions don't feel random, and they feel like the natural next step in the conversation. So this way it feels organized, expected, smooth, and this is also where examiners start to think, okay, this student knows what they're doing. So let's hear what this sounds like when we put it all together. Listen for the transition, not just the words. Here's an example flow. Can you tell me more about what's been going on? Let the patient speak. Got it. That's really helpful. I hear that this started a few days ago and has been getting worse. I'm going to ask a few more specific questions to better understand this. When did it first start? So notice what's happening. There's no interruption, there's no abrupt shift, and there's no awkward silence. Instead, we're just using open, reflecting, navigating, and narrowing. And that the entire transition takes, maybe 5 to 10 seconds, but it completely changes how the encounter feels. Let's review some common mistakes so you can try to avoid them. Number 1 is cutting the patient off too early. This just breaks rapport immediately. Even if you're thinking ahead to your next question, let them finish that thought first. Number 2 is abrupt questioning. Okay, when did it start? Where is it? How bad is it? This might feel efficient to you, but to the patient, it feels like you stopped listening, and it feels more like a checklist, not a conversation. And number 3 is skipping the transition phrase. If you don't signal the shift, it feels disjointed, even if your questions are correct. And this is one of those small things that makes a big difference in an OSCE scoring. This step is subtle, but it's a huge differentiator in OSCEs because it shows active listening, structure, and control of the encounter. And importantly, it also shows intentional communication, not just memorized questions. And it naturally supports strong summaries, organized HPIs, and clear clinical reasoning, which are exactly the things examiners are grading you on. This is often the big difference between pass and high pass level communication. If you remember one thing from this episode, I hope it's this: reflect, navigate, narrow. That's your transition formula. You don't need perfect wording, you just need a consistent structure. If you ever feel stuck in an encounter, just come back to this sequence. Go ahead and practice it yourself a few times and see if it feels much more natural the next time you use it in clinic. The next episode, we're going to build on this even further and talk about how to introduce a physical exam in a way that sounds confident and professional, not awkward or rushed. Because that's another place where students, myself included, lose points in an OSCE or just have an awkward encounter. And it actually builds directly into the same Connect framework. That's it for today's episode. Great job showing up and putting in the reps. Whether this felt easy or a little uncomfortable, that's exactly where growth happens. This isn't about memorizing scripts, it's about building a system. If you found this helpful, take a second to follow or share it with a classmate. Let's make clinical communication a little less stressful for everyone. Thanks for listening, and keep practicing. You got this, future doc.